Hello, my name is Sandra Neese. Today we will have an educational session on the pharmacological management of hypertension. The standard we will be looking at today is made by the 8th Joint National Committee, where they updated the national guidelines for managing hypertension to include the following recommendation for patients. Prior to receiving alpha blockers, beta blockers, or other recommended agents, patients should receive a dosage adjustment and combinations of the four first-line therapies. Triple therapy with an ACE, an ARB, a CCB, and thiazide-type diuretics should precede the use of alpha blockers, beta blockers, or any of the other agents. We'll go deeper into this guideline. The understanding goal is the baccalaureate nursing student will understand that pharmacological management of hypertension is an important strategy to reach blood pressure goals and reduce the incidence of cerebral vascular events, heart failure, and mortality, while teaching the patient measures to promote lifestyle changes for improved blood pressure control. Baccalaureate nursing student objectives include identify best practices of nursing care for pharmacologic management of hypertension, verbalize goals for systolic and diastolic blood pressure range, identify modifiable lifestyle behaviors that increase the risk for cerebral vascular events, heart failure, and mortality related to hypertension. And all in all, the goal is to provide an opportunity to implement national guidelines for hypertension into your nursing practice. Why is hypertension still a problem? Hypertension, known as the silent killer, continues to be a problem and requires vigilant diagnosis and treatment. Because hypertension is usually painless, it is difficult to motivate patients to take high blood pressure seriously until they have complications, which is too late. National studies reflect that by the age of 50, half of the United States residents will be hypertensive, and by 70 to 80% will have hypertension. Recent statistics reveal that about 30% of adults are hypertensive in the United States. 81% of them are aware they have hypertension, and 74% of those are receiving treatment. But of those 74% receiving treatment, only half are actually at their blood pressure goal. The risk for hypertension includes family history, age, non-Hispanic blacks, diabetes, obesity, disability, environmental factors such as stress, high dietary intake of sodium, and smoking. The antihypertensive medications we will be looking at include the thiazide diuretics. The most popular one you might know of is hydrochlorothiazide. And what these do is lower your blood pressure by increased sodium and water excretion, which decreases extracellular volume. This results in decreased cardiac output and renal blood flow. Long-term decreased peripheral resistance. It's not effective without adequate kidney function. You will want to monitor these patients' electrolytes, look for hypokalemia, hyperuricemia, and possible hyperglycemia. The next classification of drugs are the calcium channel blockers. These are known as three different chemical classifications: verapamil, diltiazem, and nifedipine. These block the inward movement of calcium, resulting in relaxed vascular smooth muscle, leading to dilated arterioles. You want to avoid high doses of these medications due to increased risk of myocardial infarction from excessive vasodilation and marked reflex cardiac stimulation. Monitor these patients for flushing, dizziness, headache, hypotension, and peripheral edema. The next classification of antihypertensive medications are the angiotensin converting enzyme inhibitors, known as ACE inhibitors. Common drugs in this class are enalapril and lisinopril. They work by lowering the blood pressure and decreasing peripheral resistance without increasing cardiac output, heart rate, or contractility. They block the enzyme ACE, which results in a chain reaction that increases vasodilation, decreases sodium and water retention by decreased aldosterone secretion, and reduces cardiac preload and afterload. Adverse effects of these ACE inhibitors include dry cough, rash, fever, altered taste, hypotension, angioedema, and hypokalemia. The next class is the angiotensin receptor blockers, known as ARBs. The most common one of these are losartan. These work by blocking the angiotensin receptors with the resulting effects of vasodilation, lower the blood pressure, and decrease salt and water retention. You do not take these in combination with an ACE inhibitor because they have a similar action and effects. Not to be taken by pregnant women either due to teratogenic effects. These patients must be monitored for hypotension and hypokalemia. Now that we've looked at these classification of antihypertensive drugs, we're going to look at the standard and that we talked about initially. And the standard goes with pharmacologic treatment strategy steps. And these are the 5 steps. Number 1, select a treatment titration strategy utilizing medications from the 4 recommended groups: thiazide diuretics, calcium channel blockers, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. On ARB, you have to see the goals of treatment for the population group and the initial medication choices. So when you select these, first you maximize the first medication before adding a second. You add the second medication before reaching the maximum dose of the first. And you start with 2 medication classes separately or as a fixed dose combination. Number 2 on the strategy steps. If patient is not at goal, reinforce medication and lifestyle adherence. Then add and titrate a thiazide type diuretic or ACE or ARB or CCB. Use these in combination, but do avoid the use of ACE and ARB together. Titrate doses to maximum as needed. If not at goal after the medication addition, step 3, again reinforce medication and lifestyle adherence and add another medication or titrate up the thiazide type diuretic or ACE or ARB or CCB. Again, avoid combined use of ACE and ARB. Step number 4, if still not at goal, reinforce medication and lifestyle adherence and add a 4th medication class. For example, a beta blocker, aldosterone antagonist, or others, and refer to a provider with expertise in hypertension management at this point. And step 5, use of the CCBs and thiazide type diuretics instead of ACE and ARBs in patients over the age of 75 with impaired kidney function due to risk of hyperkalemia, increased creatinine, and further renal impairment. What are the modifiable lifestyle changes you'll want to be teaching your patients? Promote health and control risk for the development of cardiovascular disease through promotion of a way of life lifestyle change to individuals in the United States. These lifestyle changes are adherence to a heart-healthy diet, regular exercise, avoidance of tobacco products, maintenance of healthy weight, and control lipid intake and blood pressure. What are the goals of treatment for this hypertension plan? The target blood pressures for the patients in the subgroups that are greater than 60 years old, the systolic blood pressure less than 150, diastolic less than 90. Patients less than 60 years old, systolic blood pressure less than 140, diastolic blood pressure less than 90. Patients greater than 18 years of old with chronic kidney disease, systolic blood pressure less than 140, diastolic blood pressure less than 90. In patients greater than 18 years old with diabetes, systolic less than 140 and diastolic less than 90. Recommendations per population: the general population of non-black, thiazide, CCB, ACE, or ARB initially. Up dosage or add therapy after 1 month if blood pressure goal is not met. General black population, thiazides or CCB initially. Do not use ACE or ARB together. Chronic kidney disease patients, treatment should include ACE or ARB. If greater than 3 drugs are required, a hypertension specialist is needed. Now we will take a post-test to see what your learning was on the drug classifications.